Now, moving forward, I invite Dr. Divakar Jain. He is a senior liver transplant and HBP surgeon from the Ahmedabad. He will going to talk about the decoding of the liver transplant. When to operate, how to operate, and what comes next. As the lunch time is coming to near, we have activated our pancreas, so now it's time for the liver also to be activated before lunch. Please, Dr. Divakar Jain.
So, good morning everybody. So, morning માં મેડિકલ ફિઝિશિયન સેશનથી સર્જિકલ સેશનમાં દૈવતભાઈએ સરસ ટ્રાન્ઝિશન કરી આપ્યું. Now I will continue the journey from pancreas to liver. So, liver cirrhosis, if you would have seen છેલ્લા 25 વર્ષથી જે આપણા સિનિયર ફિઝિશિયન્સ પ્રેક્ટિસ કરી રહ્યા છે તો they would agree to this point that છેલ્લા 10 વર્ષમાં લિવર સિરોસિસનું જે પ્રમાણ છે આપણી આજુબાજુ જેટલું વધ્યું છે, probably it was not that much diagnosed. આજથી 15-20 વર્ષ પહેલાં જોઈએ તો it was not diagnosed that frequently. So now if I say yes, liver cirrhosis is a problem and we cannot ignore it, but yes, we can understand it and we can fight it. So today's topic, decoding liver transplantation. I am a surgeon, so I will try to push for surgery. But I will also talk about the medical aspects of liver cirrhosis management. Now, this figure is to understand the physiology of the liver. Liver, as we know, has a remarkable capacity to regenerate. आज एक image है, we can see this Prometheus who was punished by Lord Zeus. અને Lord Zeus નો જે eagle હતું, that used to come every night, take a bite from the liver, and next morning the liver used to regenerate, right? And then he was freed by Hercules of all his problems. Now take an alternate scenario. The same guy, alcoholic, chronic alcoholic, diagnosed as alcoholic liver cirrhosis by some physician in the town. And now if you take the same person, the eagle takes of the liver, do you expect the liver to regenerate? Probably no. So that is what liver cirrhosis is in a nutshell. So liver regenerates as much as it is injured, but there comes a time when the regeneration does not happen in a healthy and normal manner, and that is in nutshell can be defined as liver cirrhosis. So it regenerates with scarring. There is destruction and regeneration of parenchyma leads to the alteration of the structure of the liver cells, and slowly the liver function goes down. So before going further, just a brief review of the causes of liver cirrhosis. Still, alcohol, whether it is a dry state like Gujarat or anywhere in the world, is still the leading cause for liver cirrhosis. But there is another cause, non-alcoholic steatohepatitis, which has been modified. The terminology has been modified to metabolic associated steatotic liver disease, MASLD, recently. And that has come as a front runner and is slowly catching up with the alcohol as the major cause. And there are some other causes like hepatitis B, C, Wilson's, autoimmune liver disease, Budd-Chiari. In pediatric patients, we have biliary atresia and metabolic causes as the main causes for liver cirrhosis. Now, before understanding the treatment of liver cirrhosis, we need to understand the 3 phases. I would say they are phases, they are not stages. Okay. There are phases of liver cirrhosis. One is compensated liver cirrhosis, decompensated liver cirrhosis, and complicated liver cirrhosis. So compensated liver cirrhosis, incidentally diagnosed, no symptoms or mild symptoms, and even if there are symptoms, they are well controlled with medicines. Decompensated cirrhosis, patient starts developing serious symptoms which need medical treatment, And complicated liver cirrhosis is when the symptoms become more advanced and patient develops specific complications like refractory ascites, hepatorenal syndrome, spontaneous bacterial peritonitis, ACLF, or malignancy. Now, why do I say they are the phases and not the stages? Because there is an interplay of all these phases. So compensated liver cirrhosis can go to decompensated liver cirrhosis, can go to complicated liver cirrhosis, on treatment can revert back to compensated liver cirrhosis. And why it is important to know? These are the clinical features. Because why is it important to know? Because the treatment of all these phases is different. These are the clinical features of liver cirrhosis which most of us know. I won't go much into details of this. Compensated liver cirrhosis, it's mainly medical management, active lifestyle, balanced diet, search for etiology. History of alcohol, ask the patient to stop alcohol. Many of these patients, when they stop alcohol, they start getting better. Drug history of anti-tuberculosis treatment or alternative medicines, these medicines to be stopped as required. Viral markers, hepatitis B or hepatitis C, they need to be treated if they are positive. Autoimmune markers, there is a role of steroids in patients with autoimmune liver disease. Wilson's disease, there is a role of chelators in Wilson's disease, which can stabilize the cirrhosis progression. Decompensated liver cirrhosis, mainly the medical management depends on the decompensation that the patient is having. And complicated liver cirrhosis, again, the patient needs to be in a specialty hospital where the complications can be properly managed. Now coming to the core topic of today, what is liver transplantation? In nutshell, when the liver becomes cirrhotic, when the patient has indication for liver transplant, you remove the whole of the diseased liver and you replace it with a new functioning liver. That is, in nutshell, liver transplantation done in two ways: diseased donor, also known as cadaveric liver transplant, and living donor liver transplant. Now, when to transplant? Now we know that, okay, once the liver becomes cirrhotic, and why don't we transplant all the patients? Because cirrhosis is irreversible, the liver is not going to get normal with medical management despite being continued for many years. Then why don't we advise transplant to all the patients? I'll come to that answer in next few slides. So again, going to the previous slide, compensated, decompensated, and complicated cirrhosis. A patient with compensated liver cirrhosis can live normally for a long time without needing a transplant. On an average, 5 to 10 years. On an average, 5 to 10 years. But as the decomposition sets in, this transplant-free survival starts going down, and it comes to an average of 1.5 years. And as the complications set in, this transplant-free survival period goes down remarkably to 3 months to less than a year without needing a transplant. Now, the question, why don't we transplant in all the patients, will be answered in these two slides. There are two things that we consider: MELD score and child score. Most of us know about it. There are online calculators to calculate this score. And this slide is very important to answer that question. If you see in this slide, if you see the first row, patients with low MELD score of 10, in those patients, the survival without transplant at 1 year is better than patients who undergo transplant. So why it is so? Because transplant is not still a 100% safe surgery. It is still a high-risk surgery. It has got its own associated mortality and morbidities. The first reason is that. The second reason is all the transplant patients need lifelong immunosuppression as such. So these immunosuppression have their own side effects and complications. That is why we do not transplant all the patients. Because patients who are doing well, probably they will do better without transplant on medical management rather than undergoing transplant. So think of transplant in cirrhosis when there is decompensation, when there is complication, when the MELD score is 14 or more, because the data proves that MELD score 14 or more do better with transplant. When there are complications, ACLF or liver cancers. There are some non-cirrhotic indications of transplant: acute liver failure, where the patient does not have any history of liver disease. So suddenly the patient presents with jaundice and followed by altered sensorium, hepatic encephalopathy, coma. within 26 weeks. That is defined as acute liver failure. Common causes are drug overdose like paracetamol, dengue fever, Dettol poisoning, hepatitis A, E, hepatitis B, C, Wilson's, and sometimes in pregnancy. And these patients, whether they will need transplant or not depends on multiple factors, and it depends on the cause of the acute liver failure, hepatitis B, C related or Wilson's related acute liver failure. They would need a transplant in more than 75% of the cases. Whereas patients with other causes like paracetamol poisoning, they probably would not need transplant in more than half of the scenarios. And clinical judgment is still the best tool to decide whether which patients would need transplant or not. Another non-cirrhotic indication is HCC or hepatocellular carcinoma. Generally, the treatment advised for hepatocellular carcinoma varies from RFA to TACE to resection surgery, but a small subset of these patients, despite having a normal remaining liver, might require transplant depending on the location of the tumor or other reasons. Then there are some contraindications. The chief contraindications are acute, active, uncontrolled, refractory, extrahepatic malignancy or infection, severe cardiopulmonary comorbidities, renal dysfunction, severe renal dysfunction which is not controlled by any treatment, active untreated psychiatric illness, alcohol or any substance abuse. The next question is, okay, once we have decided that our patient needs transplant, now how to prepare for transplant? And I am discussing this because these are the questions that our patients ask us. Patient હોય આપણા કે આપણા ફેમિલી મેમ્બર્સ હોય કે આપણા આડોશી પાડોશી હોય, એમને પ્રશ્ન થાય કે ભાઈ અમારે ટ્રાન્સપ્લાન્ટ કરાવવાનું છે અને મેં એવું સાંભળ્યું છે કે ટ્રાન્સપ્લાન્ટ બે રીતે થાય છે, કેડેવરિક અને લિવિંગ ડોનર, તો મારે શું કરાવવું જોઈએ? તો this slides probably helps us in decision making. The outcomes of cadaveric liver transplant and living donor liver transplant are same. Whether you take a whole liver or you take a part of the liver, the long-term outcomes stay the same, whether it is cadaveric or living donor. The only difference is the waiting list period. In cadaveric liver transplant, there is a waiting list time. And it is quite variable. This is 3 to 6 months. This slide I prepared when lot of donations were happening in Gujarat, but in last 8 to 10 months, the donations have come down. Probably this waiting period would have extended to 6 to 8 months. And in living donor transplant, there is no waiting period. However, there is a surgery involved on a family member who was otherwise healthy and who did not require that surgery, right? So, whether cadaveric or living donor, so it again, you see the indications in the square. Living donor transplant required when the transplant is required early and our patient cannot wait for the cadaveric organ. For example, complicated liver cirrhosis, acute and chronic liver failure, acute liver failure, the patient cannot wait for the cadaveric organ. You need to go in and do the transplant within 2 to 3 days. Hepatocellular carcinoma, there is a risk of tumor progression if the patient waits for cadaveric organ. And rest of all patients, probably they can wait for cadaveric organ and they can be advised to get registered for cadaveric liver transplant. So cadaveric liver transplant, some basic information. Again, these are the questions which are asked for the patient, how to register for cadaveric liver transplant. So the patient needs to carry out a set of investigations which is mentioned in this slide. And after those investigations, he or she can register himself or herself in a hospital which conducts liver transplant. And some basic documents which are required for registration are address proof and photo ID. And once the patient is registered, what next to be done? So regular follow-up at the local hospital. Patient from Surat can continue follow-up with the local physician. And some investigations which need to be repeated at regular interval depending on the MELD score of the patient, and they need to be regularly updated on the SUTO website. And once the patient gets the call from the hospital कि भाई organ is available, तुम्हारे transplant कराऊँ है कि नहीं, so that time the patient can go reach the hospital and get the transplant done. He can refuse also, he will continue to stay on the list, but the organ will transfer to the next eligible patient. Living donor transplant, we need a donor from the family. These are the criteria. This is another question that our patients may ask. ભાઈ અમારે ફેમિલી લિવિંગ ડોનર કરાવવું છે પણ કોણ ડોનેટ કરી શકે મને? તો 18 to 55 years of age, blood group compatibility is the only compatibility required in liver transplant. We do not need HLA matching, DNA matching or any other LCM or any other matchings. BMI should be ideally less than 30. We have taken accepted donors with BMI of 34, 35 also, but we generally do not prefer them and we discourage them. Only family related blood investigations are done once the donor is finalized, and when the donor is fit in all these investigations, then and only then we can accept the donor for living donor liver transplant. These are some images from our hospital, how we evaluate the donor. And once the evaluation is complete, the next step is documentation. Documentation to prove the relation of the donor with the recipient, and then authorization committee approval from the state committee. Post-transplant care and follow-up, I have again included this slide કારણ કે આપણા પેશન્ટોને પ્રશ્ન હોય છે કે ટ્રાન્સપ્લાન્ટ પછી કેટલા દિવસ હોસ્પિટલમાં રહેવાનું, આગળ શું ध्यान રાખવાનું. So the recipient is generally extubated on post-operative day 1. Immunosuppression is started early. 3-drug immunosuppression is what we generally follow in most institutes. ICU stay is generally required for 5 to 7 days. Hospital stay total is generally 2 to 3 weeks. And sutures are removed at 2 to 3 weeks. Long-term care, the recipient needs to be on lifelong immunosuppression. The donor does not require any lifelong medicines. Donor's medicines finish in 2 weeks. Recipient needs to be on lifelong immunosuppression. At the end of 1 year, the patient is only on one drug which needs to be taken lifelong. And generally the drug is tacrolimus. Blood investigations need to be done regularly at 3 to 6 month interval, generally CBC, RFT, LFT and tacrolimus level in the blood. No isolation is required after discharge. Patient can mingle with his relatives, generally needs to avoid the overcrowded places. And only precautions that need to be taken are clean water, clean food and stay away from unwell people. They can join work, have children, go for movies, gym, etc. And donors are not on any medication, they live normally. The outcomes of liver transplant, as we studied in the first slide, the liver regenerates if it is healthy. So liver regeneration time is generally 1.5 to 2 months, where it becomes normal full size according to the weight of the patient. The operative risk in recipient is 5 to 10%. The donor surgery is also not 100% safe. It carries a risk of 0.2 to 0.5%. And average life of the liver is normal. The quality of life of recipient and donor are excellent. There is no expiry date or shelf life of a transplanted liver. If the patient follows instructions, does not resort to alcohol and carries out reports regularly, takes medicine regularly, the liver can work for probably more than 100 years. Now, which patients to transplant, which not to transplant, whether there is any age criteria. For this, I have included these two images. On the left side is a girl, 9-year-old, who presented to us on ventilator with acute liver failure, autoimmune liver disease related. And on the right side is an old man of 71 years of age. Okay, so generally if you think that, okay, these two patients, such a big surgery, whether we need to do transplant or not, but you see this patient, 71 years on 8th day post-transplant, is reading newspaper, riding exercise bike, and this girl is sitting with me in the OPD after 2 months. We did emergency liver transplant. Devat Bhai, who did the first presentation, was a part of the surgical team that time when I was in Zydus. So this patient is still doing well. It is 3 years after transplant. She is going to school. She is doing regular sports activities and everything. And she is dreaming of becoming an artist. So, and there are some scenarios where early transplant is needed, but no donor in the family. So there are some innovations. One is dual lobe transplant. Our hospital is the only hospital in Gujarat which has done dual lobe transplant, where we have taken 2 livers from 2 different donors and did transplant in one patient. Swap transplant, where one donor from one family donates liver to the other family, and vice versa. ABO incompatible transplant. These are the 3 ways. Last slide is on organ donation. I would like to talk on this topic. There is a huge gap between supply and demand of organs right now. Many patients, many people have road accidents in our country. Approximately 1.5 lakh deaths happen annually because of road traffic accidents. But against this, the number of transplants that happen, the number of donations that happen is quite low. Although I agree that Surat is the front runner in organ donations right now, in not only in whole of Gujarat but whole of India. But still we have not reached yet to that level where we can offer organs to all our patients. The process of organ donation is very simple, and generally the whole thing finishes within 24 hours and the body can be given back to the family. To conclude, patients with liver cirrhosis may live for a long time without needing a transplant. There are definitive indications for transplant, and transplant is the only curative option for cirrhosis as well as for some non-cirrhotic liver conditions also. Transplant gives a normal survival and a better quality of life, and perioperative optimization is the key to provide good outcomes. Thank you.
BRTs and plates in short. Sorry? The using of BRTs and plates in compensated cirrhosis of the liver. BRTs and plates, I'm asking to put, they are putting like stent, I think.
So, see, basically, the first question, immunosuppression, yes. Any medicine, whether we give, whether even if it is simple pantoprazole has got its own side effects. Immunosuppression, they have definitive side effects. The steroids that we give in the early post-operative period, they increase the blood sugar levels, and patients need insulin for early management. Long-term steroids we don't give in our patients, but if some patients require long-term steroids, they can have weakness of bones, infections, risk. All immunosuppression reduces the immunity. So yes, we, for initial 3 to 6 months when the patient is on 3-drug immunosuppression, we advise the patients to avoid overcrowded places, and whenever they go out, they need to wear a mask. The major problem that we face with immunosuppression is renal side effects. Because the medicine that we give lifelong, the tacrolimus or cyclosporin, is nephrotoxic, and in the long run, over 5 years or 10 years, they can cause serious complications and serious side effects on the kidney function. So that is why every 3 to 6 months, the reports that we do, they include the renal function test also. So if there is some alteration in the renal function test, we can modify the dose of the immunosuppression or change the immunosuppression to other immunosuppression. There are a couple of patients of mine who are right now, we have stopped tacrolimus and the patient is on mycophenolate and very low dose steroids, and they are doing well. Their renal function became normal after stopping cyclosporin and tacrolimus. Coming to your question, sir, BRTO I think you were talking about, right? BRTO? You're talking about stent?
Yes, sir, yes.
Stent?
BRTs or clips.
Okay. So see, those
Balloon
are...
retrograde.
Yeah. So I think you are talking about the GI bleed patients who come with GI bleed.
Yeah.
Yes, they have definitely got role in patient management, as I discussed, that there is an initial phase of the liver cirrhosis where the patients do not need transplant. So they can do well on these management, they can continue for a long time, because once you have obliterated the varices or you have controlled the bleeding, and if the patient stops drinking alcohol, they become stabilized for a long period without needing a transplant. So yes, they have definitely got a role, but they do not cure the liver cirrhosis. The liver does not become normal, unfortunately, on any medicines or any interventions available right now, except for liver transplantation. So there would be a time when these patients would require transplant.
Thank you so much, sir, for providing such a detailed roadmap to liver transplant. I request Dr. Vinod Shah, sir, and Dr. Prashant Karia, sir, to felicitate Dr. Divakar Jain, sir.